We are going non-stop from 8 o'clock, thanks to Dr. Govindraj, Vijay, and all the people out there in the UK. I can see Hari and Krishna Rao sir, and all other people are there having a very short, ultra short break of lunch. We are back in the post-lunch session, starting with the expert lecture. To introduce the chairpersons, I invite Dr. Govindraj to introduce our chairpersons, Gani Bhaskar Rao, LP Tangavelu, and Dr. Hari Krishnan. A quick word before you go into your own topic, Govindraj.
Yes. Good afternoon, Ishwar. Thanks for the introduction. And here we have Dr. Hari, one of my very close friend. He's from Sheffield. He's one of the directors in the field of colorectal surgery there. And welcome, Hari, to this platform. And we have one of our stalwarts in the field of surgery from Raja Mahendra, Dr. Gani Bhaskar Rao, who is the chairman of the JSL Medical College and who himself is a prolific surgeon, who has brought India to the field of simulation in the art of laparoscopy and endoscopy. Welcome, Dr. Gani sir, and of course our colleague Ishwar and Dr. Vijay from Aurangabad. And Vijay is the one who demonstrated the inflammatory bowel disease colonoscopy very well in the morning. Thank you, Vijay. That was a wonderful demonstration. And I think we are ready with the lectures. We can go ahead. Go to Ishwar.
Yeah, just a minute. Just a housekeeping announcement for the next 3 hours. So I'll be sharing the session, trying to streamline the influx of our chairpersons because they are getting the link login ID only 15 minutes before that. Once you come in, except the chairpersons, all of you please keep yourself muted. The chairpersons also, if they have some background noise, if you prefer, or if you are having more than one device, keep yourself also preferably muted until the question time. We are going by clock. There is a timer. So the first talk is for 12 minutes. Then 3 minutes will be there. And I request each person in their own specialty, the first repeating about the talk on maximum of 1 or 2 questions. And as soon as the 15 minutes will automatically shift. So that's the only way we can finish the whole proceeding in a smooth, seamless manner by 6 o'clock for the preliminary sessions. So let us go to Dr. Govindraj speaking on SEM stenting, the role of it in surgical leaks. Over to you, Dr. Govindraj.
Good morning, everyone. My topic is a very interesting topic. It's about how you tackle leaks, particularly whichever kind of leak you happen to have in the post-operative period. It has been a bugbear in a surgeon's mind for a long period of time. And this topic of stenting, particularly for a post-operative leak, has become a kind of a solution for most of the time nowadays, particularly after the advent of this bariatric surgery. The surgical leaks, which have been estimated around 1 to 17% after most of the anastomosis, and particularly after the bariatric procedures like the sleeve gastrectomy and the ROAGB, it was highly common. In the initial part of the bariatric surgery, it was very difficult to find a leak in the early period. And depending on the leak, it was classified depending on the time of the leak, depending on the severity of the leak, and depending on the site of the leak. So based on the time of the leak, it was classified into early, which was 1 to 3 days from the time of surgery. Intermittent, it was around 4 to 7 days, or intermediate 4 to 7 days after surgery. And late, which was around 8 days after surgery. And depending on the severity, we classified it as type 1 and type 2. Type 1 is basically a subclinical leak where the presence of the leak does not warrant major intervention, and it is without dissemination and without sepsis. And these patients have initial some kind of a vital signs abnormality, then they settle down on their own with conservative management. And the second type is a type 2 leak where clinically the patient becomes sick. The presence of the leak is with dissemination and with septicemia, where he needs definite intervention by the surgeon of the team to come out again. And the management of the leak, the general guidelines are either conservative, as I said, or intervention but no re-exploration. Third type is intervention with re-exploration. The second type is intervention with no re-exploration. It's a very small amount of cases. Either they are conservative or intervention with re-exploration happens. And the re-exploration has been now turned towards stenting. A small introduction about the self-expandable metallic stents. These stents, they vary from sizes from 6 to 19 millimeters depending on the area, on the length, on the site where you want to put. It's generally made up of a material called nitinol, which has been there for ages together, almost 2 decades. It has been there 2 to 3 decades. And it is usually your fully covered stent we use for a leak. Previously, there was an era where there were partially covered stents were used, but nowadays we use fully covered stents. Wallflex, Evolution, Ultraflex, Alimax, EVT, Niti. These are the various companies which manufacture stents today from various parts of the world, right from America to the eastern part of Asia also. And this is the picture where you see majority of the stents are there. And you can see in this, I have not mentioned anything. These are the most stents which are used in the esophagus for a leak, or particularly in the lower esophagus or the cardioesophageal junction. These are the stents which are used for it. Now I am going to give a gist of various types of stents which have been used in the market and their uses. If you look at the third tabular column here, that is a SEP stent, that is the plastic stents. They are completely out of the market because the migration chance, if you look at this, is very high. And the migration chance is so high because you put in a stent today, 3 days later, the stent gets migrated. It has completely gone out of the market. The biodegradable stent, it is a very new thing which is coming up in various parts of the country and different parts of the world. And the migration chance is very low. And this is one of the stents which can be used particularly for surgical leaks. And there's a lot of research that should be done on this biodegradable stent. Now the commonly used stents for these leaks are the fully covered stent. So fully covered stent, if you look at the first tabular column, the migration chance is still high. The tumor ingrowth, or because we are not talking about the tumor ingrowth there or tumor overgrowth there. And important thing is it's a removable stent. Now nowadays most of the stents we have to look at it is for a 3 weeks to 6 week period, particularly for a surgical leak. It should be a removable stent. So these fully covered stents are a removable stent, and closure of fistula or leak is very high in this. So this is the commonest that we use nowadays. And the efficacy of the stents, if you look at it, they show an improved oral intake in 95% of the patient after you place in a stent, and the stent has been in position for minimum of 3 weeks. The oral intake definitely improves. And patients who have developed a tracheostomy fistula, they give almost 70 to 100% success rate, and that is usually malignancy. And the adverse effects, any stents, if we classify, the adverse effects can be classified as intra-procedural, post-procedural, and delayed complications. And if you're looking at the intra-procedural, the commonest thing, it appears whether it is a malignancy or it is going to be for a leak, malposition, the aspiration. That is the reason nowadays we do everything is under general anesthesia. The patient is intubated. Perforation, that is another chance that can happen, because if the positioning of this it is going to be difficult, and if we are going to give more pressure, already there will be edema, perforation can be high, and bleeding usually occurs 3rd day or 4th post-stenting. And the post-procedural stents are complications are chest pain, the foreign body sensation, particularly if it is in the upper part of the esophagus or the upper part of the stomach where the leak is, or sometimes it can produce a tracheal compression, and there can be stridor also. There have been instances there have been stridor also. And delayed complication occurs 2 to 3 weeks after the stenting, that is stent migration. And TE fistula, it's very rare when you put it for a leak. It has not been very well documented, very minimal number of cases are there. And the bronchoesophageal and the stent occlusion happens only when you put it for a malignancy. And this is one of the stents which has completely revolutionized the anastomotic leaks. It is called beta stent, and it's from a company called Niti. And it is a Korean company which manufactures stent. And if you look at the stent, the Niti stent is a fully couple bump stent. If you look at it, there are 2 bumps there, and it is basically designed for the staple line leaks. Basically, at the staple line, if you have a leak post-bariatric, and these 2 bumps, between these 2 bumps, the leak area should be placed. And it's over the wire, you try to place it, this stent, and it has got a proximal phalange there. This proximal phalange is thickened by silicone covered by a double stent, and this reduces the chance of migration. And That is basically the most commonly used stent nowadays, particularly for a post-operative leak. There is one more stent from the European Union, that is the ELA stent or SX ELA stent. And this stent, if you look carefully into the weaving pattern, there is a difference in the weaving pattern, and there's a wider diameter stent. And along with that, you can see two loops, silicone loops at both ends. So it is easy for retrieving this stent. And this stent is also being used particularly for post-operative leaks, particularly in the esophagus and the upper part of the stomach. And here I'm going to show two interesting videos here. This is one case which was referred here, just one case. Patient was referred after 8 to 9 days post-surgery. It was basically a oncological surgery for which the upper part of the stomach they have done at the gastrectomy. And post 9 days, the patient had a leak. They are diagnosed the leak by using a CT. And then the patient came to me. I did an endoscopy. If you look at the endoscopy image here on the left side, I've gone into the esophagus there. At the esophago-jejunal anastomodic side, there is a nice fistula through which I've entered into the fistula there. I'm entering into the fistula there. You can see there in the nice fistula there. And after in the fistula, you can see collected material there. And the fistula, I could not go beyond the fistula there. Then I decided to stent this huge fistula gap that is there. You can see nicely the stapler. You can see nicely a stapler is there. And the stent is, the stapler has been, the completely stapler line is seen there. And if you look at the next video, the second endoscopy day, I did that endoscopy. And that day, I can see as I went inside, I was seeing the communication between the fistulous area and to the small bowel there. It was a communication from, you can see a nice hole in the fistulous area. From that, I put in the scope. I was entering into a small bowel there. You can see that. I fast forward that. I've entered into the small bowel there. It is a distal ileum where I'm entering there. So there is a communication from the pouch to a distal ileum there. So what I did was, I put in a stent there and allowed the patient to go home and asked him to come back after 3 months. After 3 months, the patient was able to eat completely. Then I removed the stent. As I removed the stent here, you can see the image here. Completely fistulous tract had disappeared, except for a small kind of a pinhole-like area that is seen there. If you look carefully on the 9 o'clock position on the screen, you can see a small pinhole. That's a pinhole there, which you can see there. That's a pinhole there. That's coming up. And absolutely after removing the stent, the patient is absolutely fine. And this has completely revolutionized the way in which the patient was treated. This is a previous image. It's been coming back again. This is a previous image. So another important area where I have witnessed is the post-lap chole leak. And the commonest reason for a lap chole leak is the slipping of cystic duct and common injury to the axillary duct and complete transection of the main bile duct, or numerous classification has been used for the injury. Most of you know what is Strasbourg's classification. According to Strasbourg's classification, these are the various types of injuries that occur which causes a leak in the bile duct. Here I'm going to show an image where post-lap chole, the patient was referred to us with a leak here. I have done an ERCP here and I'm trying to inject a dye here. You can see nicely the dye is leaking out. Here you can see the clip here, and this is a Strasbourg 3 classification here. You can see near the hepatic duct there's a leak here. But I have put in a guide wire. What I did was I put in a stent, a SEMS completely covered stent, and I removed the stent after a period of 3 weeks, after a period of 6 weeks. The patient is absolutely fine here. Only thing is, after removing the stent, you have to be very careful, all the follow-up the patient to look for any collection post removal of the stent here. And this is another case of a post-lap chole leak. You can see a T-tube has been placed by the open surgeon, but it's not a lap chole, it's an open surgery there. And the patient had, the surgeon had kept a leak, the T-tube there. You can see after I put in a ERCP, I tried to inject a contrast there. You can see the T-tube here, and you can see 2 leaks there. One is the proximal leak and the distal leak. What I did here was, I put in a plastic stent across this, and the patient went home fine here. And leaks in particularly bariatric surgery, as I said, it's very common after RAGB, and it's 6 to 14% is there, and stents have come to stay as a main way. And last but not the least point, evac therapy has been tried in very many centers. I don't have any personal experience of evac therapy, particularly in this. I have taken a few of the videos for courtesy from the SAGES also. And here you have a video here where we have done this here is a fistula here after a sleeve gastrectomy. And you can see I'm putting the scope into the fistula tract here. Here we have kept a tail at the collection center. Collection by the ultrasound we have done. I'm putting a regular stent here. It's a regular stent here, fully covered stent here. And the stent was kept for a period of 8 weeks. The patient became better. But only thing is, after 8 weeks also, we had to continue the stent for another 2 weeks after I checked in the CT scan that completely the pouch had not disappeared. So we kept it for around 8 weeks and then removed the stent. The patient went home fine. So this EVAC therapy is a new concept which has come. It is called endoluminal VAC therapy, but it is just like open VAC therapy what we use there. And we use to deliver a negative pressure to the leakage site. The negative pressure can be created by using an endosponge. It is a polyurethane endosponge that is placed into the cavity or just at the neck of the cavity. It is kept through an endoscope. It is kept. I have taken a video from the SAGES, and thanks to the SAGES video here. Here, what they are doing is they are putting the endosponge, that they are attaching it and tying it to the tip of a cannula there. And the cannula is brought into the endoscope here. You can see the endoscope. The cannula is brought into the endoscope. And using the holding with the biopsy forceps, they are placing this sponge at the tip of the leak where there is a leak there. The fistula tract or into the cavity, the sponge is placed. This is how a VAC therapy is placed. And this VAC sponge can be removed after a period of 3 to 6 weeks. That can be removed completely. They have said there are a lot of papers coming up where the VAC therapy has been very useful. And the main mechanism of action is creating a negative pressure which can be applied. And it can be attracts into the pores and it sucks the area from collections and it decontaminates the area. And this is how it heals. And this is a new concept which is being developed. And particularly in oncological surgery, the leaks have been 3 to 25%, particularly in the gastric leaks, around particularly gastrojejunal, it is 53% following a gastric pouch. And the common site of gastrojejunal point is the commonest site of the leak. And in conclusion, what I have to say is, stents have reduced the mortality and the morbidity in gastrointestinal and hepatobiliary surgery by 60 to 70%. The role of stent should be very judiciously employed, particularly depending on the time, site, and severity of the leak to have the best results. And use of endoluminal suturing and clips are being studied in a big way as an alternative to stents, particularly in early leaks. There are papers to come out. Thank you so much.
Thank you, Govindraj, for your excellent presentation. We have just 30 seconds. Dr. Gani Bhaskar, what do you want to say regarding the presentation?
Seeing leaks, most of the leaks will go to gastric. What is the difference between the medical gas and surgical practicing the ERCP? What is the outcome difference?
We'll answer that question. Yeah, we'll answer that after the next session where he'll come back. I think we'll go to Vijay. He's waiting, and let us go to the management. Knowledge about how to manage a lower GI bleeding from a surgeon's perspective.
Good afternoon, Mr. Chairman, sir, ladies and gentlemen. At the outset, I bring greetings from my hospital, Seth Nandalal Dutt Hospital and Krupamai Hospital, India. The subject of today's presentation is management of lower GI bleed, surgeon's perspective. Lower GI bleed is defined as an intraluminal blood loss from a source distal to the ligament of treats. The incidence is about 1 to 2% of all hospital admissions. Almost 85% of the GI bleed, they are from the upper GI and 15% from the lower GI. 85% of the lower GI bleed, they come from the colon, 10% come from the upper GI, and 3 to 5% come from the small bowel. Overall mortality rate is 4 to 10%, depending upon the comorbidities and the seriousness of the case. The clinical presentation is, patient can present with an occult blood, melena, hematochezia, hemodynamic changes, pallor, fatigue, chest pain, dyspnea, stroke, cardiac events, and shock. Etiologically, The lower GI bleed can be because of angiodysplasias, diverticular diseases, polyps and polyposis, inflammatory bowel conditions like Crohn's, ulcerative colitis, pseudomembranous colitis. Neoplasia is Ryle's tube aspiration. Even though patient is bleeding from the lower GI, in about 10% of the cases, quite significant number of cases, they can have their source of bleeding in the upper GI. And this simple Ryle's tube aspiration can define whether we are dealing with the source from which the patient is bleeding. This is the overall protocol for management of the acute lower GI bleed. We categorize the patients in two categories. Number one is the patient with lower GI bleed with no hemodynamic changes, and the patient with the hemodynamic changes. We must investigate all these cases in a fixed protocol so that we spend no time unnecessarily in investigating the case, and we get at the source of bleeding as early as possible for the right management. The first and the foremost investigation should be done, even though patient is bleeding from the lower GI, is the upper GI endoscopy. When patient has got hemodynamic instability, in that case, apart from the upper GI, lower GI, and the CT scan, one more investigation comes into picture, that is the angiography. The patients who are hemodynamically unstable, they can be studied with the angiography. It can detect the bleeding also. It has got therapeutic capabilities. We can do the angioembolization. However, the risk of producing bowel ischemia by angioembolization should always be kept in mind. Now, this is one case who presented with severe lower GI bleed. He had a hematochezia, but as a protocol, when we did the upper GI scopy, we found that there is a fleshy mass in the second, third part of the duodenum, which was spurting and actively bleeding. Now, this was middle of night, and the only thing was first to have a full control over this bleeding. It was done by putting a glue therapy. A cyanoacrylate glue was injected in this bleeding source, and the bleeding was arrested. Then thereafter, we studied the patient next day again, and this was the fleshy mass that we were talking. And this is the source of bleeding, the point of bleeding. It was totally occluded by the cyanoacrylate glue. The patient was studied further with the CT scan, was found to have the GIST, the gastrointestinal stromal tumor, and was successfully resected later on. This patient had severe fresh bleed from the rectum, and the patient was hemodynamically going unstable. Endoscopy revealed that he has got a very fulminant type of ulcerative colitis with bleeding, and underwent pancolectomy in emergency. When upper GI scopy and both lower GI scopies are negative, the investigation of choice that comes is the MDCT. And here we get some of the conditions which are related to the small bowel, which can be seen on the CT scan. And here, as you see, that there was a mass in relation to the jejunum, a large mass. It was again diagnosed as the GIST, gastrointestinal stromal tumor. They are known for the GI bleeds, and this mass was further successfully resected in emergency. The Meckel's diverticulum, when even the CT scan is negative, the upper GI scopy has not been rewarding, lower GI scopy has not been rewarding, CT scan has not yielded anything, then of course we suspect a Meckel's diverticulum, particularly when both upper and lower GI scans are endoscopies are negative. And this can be done with a technetium pertechnetic scan. It is pretty specific for the Meckel's. As you see here, there is a concentration of the radioisotope, and these patients can now further be treated either laparoscopy or by open surgery, and the Meckel's diverticulectomy can be performed. Now, this patient, here we had to do a push enteroscopy because even all the scans were negative. Upper GI scopy was negative, lower GI scopy was negative. CT scan did not fetch us any more information. And in this case, a push enteroscopy or the double balloon enteroscopy was performed. This patient had undergone a previous ileal resection because of thromboembolic phenomena. And this patient was bleeding from the anastomotic site. And further, we again offered in emergency the resection of this anastomotic site where from the patient was bleeding. The intraoperative enteroscopy is really a boon to a surgeon who confronts with such a massive lower GI bleed. And again, these are the cases where all the investigations have failed to reveal any positive information about the bleeding. And this can be done by a general surgeon with control over the endoscope. And for this procedure, the patients are again somewhat hemodynamically unstable. They are younger patients, they have got a better longevity, and they don't have any comorbidities. All these cases are selected for the intraoperative endoscopy, and this can be done in any peripheral hospital for that matter, those who have got facilities for the upper GI scopy. Now, systematically, we see the bowel against the operation light, and the entire small bowel right from the jejunum to the ileocecal junction is seen against the light, and transfiltration is seen. We can see a nice vascular pattern as you see here, and if at all there is any vascular malformation, this can be noticed on this by this way. If you don't see anything on this, then we do an enterotomy in the mid-ileal region, and then the gastroscope is passed into this small bowel to find out the source of the bleeding. And then, as you see here, we have done an enterotomy, and we have passed an GI scope into the lumen, and we detected that there was a malformation, vascular malformation, which was actually bleeding. We could have tackled this by endoscopy, but however, the patient was young. The patient had lost a lot of blood. We never wanted to take any chance, and the patient was treated by resection of this segment of the small bowel. So this operative enteroscopy is really a boon for a general surgeon who confronts with a massive upper GI bleed, lower GI bleed. And this technique has appeared in the British Journal of Surgery 2011, and this was on the cover page as the point of technique in the surgical practice. And this was the picture, and this is what we had done at our center. Now, this is another case where a middle-aged patient was massively bleeding per rectum, and he was bleeding for nearly 3 to 4 years before he came to us, and he was again misdiagnosed as the hemorrhoids and had undergone multiple sittings for the sclerotherapy, kept on having a torrential bleed, going for anemia 3 to 4 grams every time, and required multiple blood transfusions. On colonoscopy, we found that there were multiple hemangiomatous malformations which were there in the rectum and the entire colon. These malformations were spongy, they were even pulsatile, and there were some risk spots which showed that there could be possibility of an acute bleed in future. MRI is very sensitive for further investigations, and we performed this MRI, and this is MRI pelvis, where we find that the entire rectum is replaced by a very spongy, is very thickened up, and it is replaced by the large cavernomatous malformations which are containing the blood. And there are certain areas of calcifications which are very specific for the hemangiomas of the rectum. As you see here, there is a severe luminal compromise. Almost the entire rectum is full of this hemangiomatous malformation. We studied this in the sagittal section, and here we find that even the rectum, the colon, and the anorectum, even this hemangiomatous malformation is coming in the anoderm and into the skin. So this is a very extensive variety of hemangioma of the rectum and the colon. This patient, we offered surgery, and here on laparotomy, we notice that not only the luminal, but there were even large hemangiomatous malformations spread all over the mesocolon, and small bowel and the mesentery of the small bowel were free of lesions. So in this case, we decided to do a pancolectomy along with APR, abdominoperineal resection, to control this bleeding. The surgery was taken in a very systematic way. We had taken control over the inferior mesenteric artery. We took control over both iliac arteries, and also we had dissected the external iliac arteries and kept them under control. And the part of the area that we were dissecting, suppose if you are doing the colectomy, we had controlled the inferior and the superior mesenteric artery for some time. And while we were doing the pelvic dissection, we had a control over the internal iliac arteries. The entire rectum was so spongy that there was no space between the bladder, and the entire pelvis was full of this rectum. The moment we controlled these internal iliac arteries, the rectum collapsed, and the hemangioma also drained out, and it was possible to perform the abdominal perineal resection. So this is a specimen where we find that right from the anorectum up to the entire colon, there are areas of the hemangiomatous malformations, and this patient was offered a permanent ileostomy. Double balloon enteroscopy also comes to rescue when there is a small bowel bleeding. As you see in this case, the angiomatous malformation bleeding from the small bowel and was controlled with the argon plasma coagulation, and the bleeding stops. The indications for emergency surgery for severe lower GI bleeding are a sustained hypotension and shock despite of resuscitation, lack of diagnosis despite of colonoscopy, push enteroscopy, nuclear scan, and angiography, no associated comorbidities, and reasonable life expectancy. These are the cases where we must have the surgical options at our armamentarium. The message is lower GI bleed is a rare but constant surgical emergency, needs systematic protocol approach to optimize the results. Early referral to the higher centers with optimum diagnostic facilities helps to improve the results. The choice of diagnostic and therapeutic methods depends upon the clinical scenario, bleeding rate, and availability of the resources. In rare situation of colonic bleeding, not localized specifically, a subtotal colectomy is safe procedure of choice, but nowadays it is rarity. Documentation of these cases with anecdotal experiences guide us to treat these cases in future. Thank you.
Thank you, Vijay. You kept the time nicely for 2 minutes. Hari Krishnan, would you like to add something? Because you're a colonic surgeon, I gather, from UK.
Yeah, that was a very comprehensive, expert oration on lower GI bleeding. I do have to congratulate Dr. Gonkar for this masterly presentation. I think he covered everything, all possibilities. Just the practice we have a high percentage of lower GI rectal bleeders, emergency and semi-electively. Upper GI endoscopy is the first step. So all of them get an upper GI gastroscope, and then if they're bleeding briskly, they straight to angiogram, and then they're embolized. If they're not briskly bleeding, and then we resuscitate them, and then many of them have video capsule endoscopy. We have a very good video capsule
Yes,
unit
Vipul,
here.
ready? Are you ready?
I'm ready, but you get the screen I'm also ready.
Yeah, I'll find out.
We have a video capsule, small
Yeah.
bowel and colonic options here. So we have picked up a lot of lesions there and treated those. So it's a very well covered topic. Thank you very much, Vijay.
Thank you. Thank you.
While we are taking the next question from Dr. LP Thangavelu, our organizing chairman for 2021, Vijay, I ask our coordinators to allow Dr. Vipul to enter in the hall because he is going to make the next presentation. Thangavelu LPT, you want to add anything? And congratulate our EC member from the West. Wonderful presentation, Vijay. We really like the way you demonstrated this morning, the colonoscopy 2 in a short spell. Now, 15 minutes non-stop, a comprehensive, it's textbook description of how to talk. LP Thangavelu, can you unmute yourself? Otherwise, we are ready for the next presentation. I think we have Vipul. I think he proved ourselves how efficient in a given time of 10 minutes he was able to convince how important the US in the hands of the proper personalities, it can be an effective therapeutic tool. I think he's a mounting personality from Mumbai. I think with his experience and enthusiasm and energy to take the US to nook and corner of the country, we need people like him in the IAGES teaching under the guidance of Professor Sir. So it's all we are. You told something about the biliary. Now you are entering the pancreatic. So you are entering the next nation. You are invading every territory, the surgeon's territory. But basically, you are a surgeon. Welcome, Vipul.
Thank you very much, Eswaran, for such a wonderful, kind introduction. And my warm welcome to all the panelists and chairpersons, India and UK. I'm going to take you through a very quick. It's impossible to cover the entire, thing in a short period of 12 minutes. So I'm going to focus on one or two areas which I feel has not been talked about in surgical meetings or even in endoscopy meetings routinely. So guys, when we talk of pancreas, it's a very complex organ, and somebody very well put it someday that it was first described in 1788. Then it's such an enigmatic organ, and the process of the pathology, diagnosis, and treatment always was unpredictable. And even today, I'm sure all of you would agree that pancreatic disease are one of the most difficult areas to diagnose accurately and treat effectively with long-term outcomes. So I would like to cover the role of EUS in diseases of pancreas. So if you ask me, the entire list you can see over here: acute pancreatitis, recurrent acute pancreatitis, chronic pancreatitis, pancreatic fluid collections, world of pancreatic necrosis, cystic and solid tumors of pancreas, EUS-guided celiac plexus neurolysis or block, EUS-guided pancreatic duct drainage, as well as you can also do fiducial placement, EUS-guided, as well as some RFA therapy, which are still very, very experimental. So I'm not going to talk about all this. It's impossible for me to cover. So I'm going to talk of a couple of things which are very relevant for surgical practice worldwide. So I'm going to talk about role of EUS and endotherapy in various pancreatic diseases. Turn a little bit of technical aspect. I'm not going to go into too much of technical details of the equipment, but what I'm going to talk about how to manage undilated ductal systems in recurrent acute pancreatitis. So I'm going to talk about. Now, this is a classical pancreatic image which one would like to see in color. Unfortunately, still the technology of EUS has not allowed us to do that, to see in color, but very soon, I'm sure in coming years, we'll have computer graphics which will give colors to all these problems, and we'll be able to make a better impression of EUS on pancreas. So I'm just going to guide you through some of the videos for the ease of our colleagues here. So patients with pancreatic endotherapy, when we take them, we personally would like to map the whole pancreas, and this is one such patient who had negative CT angio on pancreatic chronic pancreatitis, and what we saw was a frank bleeding from the ampulla, and even a direct angiogram could not pick up a pseudoaneurysm. EUS, we ruled out a pseudoaneurysm, but what we realized was that there was actually probably a vessel eroded in the ductal epithelium, and that was bleeding. Now, why I'm sharing this video in detail with all our colleagues across the world, especially in UK, that the chronic pancreatitis which you see in West is predominantly alcoholic. Now, this guy had never touched alcohol in his life. And what kind of disease which we come across in India, especially in this part of the country, I'm showing Western India and some of the parts of Central India, that this is the kind of soft stones we see in the pancreatic duct. And this is the kind of pathology which can be very, very well amenable to endoscopic treatment. So EUS gives me a mapping. I'm going to share a few more things on that. But when you talk of recurrent acute pancreatitis, we all know gallstone, alcohol, ductal anomaly, and all the other etiologies. Giving you a small idea of chronic pancreatitis, as you saw earlier, similarly, this patient had multiple problems, multiple episodes of pain. And you can see, I'm going to show you something. This is a soft stone in the pancreatic duct. Now, because of lack of calcification, of course, poor imaging in other centers, this stone was missed. And I think on endoscopic ultrasound, we were able to pick this stone. And then this girl really benefited with a very aggressive endotherapy protocol. You can see the whole pancreatic duct dilated. And then we cleared the duct of all the stones. And in pilot endotherapy only, we prefer to put 2 7 French or 2 10 French stents in the pilot endotherapy protocol. Because of dilated duct, no strictures, only prepapillary narrowing and soft stones like this. So we deal with a very, very different kind of chronic pancreatitis because of genetic mutations or some other reason we do not know. But this is how we have very aggressive approach, and this is beneficial for patients, especially younger age group. Coming to same way, we map always the pancreatic duct. You can see the stone in the pancreatic duct beautifully depicted. This is the CBD. You can see 2 stones there. And at the same time, we do pancreatic endotherapy on the same table. So any patient with acute pancreatitis, recurrent acute pancreatitis, or established chronic pancreatitis, it is one table diagnosis and solution. This is possible when you have mapping of the gland where the disease is purely ductal, no inflammatory head mass, no tumors, no parenchymal calcifications, and you have pure ductal disease. This is what I think should be practiced in all leading pancreatic units across the world, as I feel. I've been doing this for the last 22 years in India. So I'm just going to give you a couple of examples, non-dilated upper CVD and all other pancreatic masses, a patient with case capsule 25 complaints of pain in upper abdomen and pancreatitis since 2011, going round and round and said nothing can be done. And then you see this kind of a picture. On MRCP, nothing very clear. But I want all of you to pay attention in a very, very interesting video. This is what I talked about, undilated ductal systems. Ladies and gentlemen across the world, I'm doing an endoscopic ultrasound. This is a gallbladder. I'm going to show you, this is an acute pancreatitis. So I intervened in recurrent acute pancreatitis. Patient had amylase of around 234, 240, lipase around 700-800. And we saw the prepapillary CBD, and you can see a small stone in the minor papilla. I'm showing you a very tiny 3 millimeter stone in the minor papilla. Now, this is impossible to pick up on all conventional imaging known to mankind currently, including a direct ERCP. You may miss this small stone of 3 millimeter. So EU has allowed us undilated ductal system access, diagnosis and treatment. And this patient also had an incomplete divisum. So we did a major papillar sphincterotomy. And then you see what happens when I do a minor papillar sphincterotomy. Immediately a small stone which was picked up on EUS will pop out, and this will stop the recurrent attacks of acute pancreatitis. So what I feel is that undilated duct, there are some studies from Europe now, Northern Europe, where they've shown that early surgery in undilated duct is also equally effective, and it is better to do early in undilated systems than late. I'm going to skip a couple of videos, but these are very, very complex procedures which we do because of US mapping. Again, it allows us to map the duct, the parenchyma, and all the structures of the pancreas in great detail compared to other imaging studies. And therefore, we have integrated endosonography as a primary tool for mapping of pancreas prior to any intervention. As you can see, this is pure pancreatic head, no calcification, a large soft stone in the genu. And I'm going to run a parallel video where you can see a lot of stents around. So we cannulated this pancreatic duct. You'll see how the picture pans out. And this patient has an incomplete pancreas divisum, and we managed to drain. You can see there's an S-shaped duct here. So we managed to do multiple stent placement through the minor papilla. So what I feel is that it is extremely important for colleagues to understand that pancreatic endotherapy as a subspecialty, a proper diagnosis and staging or mapping of the gland is vital to long-term outcomes. And this is something which I want to impress on the audience today. Coming to young children, now pediatric, as I said, we had patients who are as young as 20-month-old baby. I'm doing an endosonography with a regular adult EUS scope because I wanted to map the pancreas before we intervene. So even in children, recurrent acute pancreatitis, you need proper mapping and then proper. So this child had a small fluid collection impinging on the pancreatic duct in a setting of incomplete pancreas divisum. Now, these are little complex black and white images, not very easy for most surgeons to read if you have not seen too many US pictures or images or videos. But I can assure you that if you have a very strong arm of US in your department, you can probably do some of the finest pancreatobiliary interventional endoscopy work known today. So immediately we went ahead, and I'll explain to you when we cannulated the main pancreatic duct from the major papilla in this young baby of 20 months. And we went inside the duct, you can see here. And as soon as we injected contrast, the small fluid collection filled up here, which was impinging onto the pancreatic duct, and that was causing the child not to thrive. I think I've already shown this, but I want to share what is the role of pancreatic EUS in tumors. We all know the importance of EUS in solid tumors, and this was one such case of a large mass in the head of the pancreas in an 18-year-old male patient with obstructive jaundice. This young man was advised surgery at various centers in India without diagnosis. So we traditionally do EUS-guided core biopsy. We always do EUS-guided proper biopsy now. And on histological specimen, we found this is a CBD obstruction here you can, and this young boy had a primary tuberculosis of pancreas, and he obviated need for surgical intervention, and he was treated with antitubercular drugs. So this is how the stricture will appear on a cholangiogram. We took brushing also. Brushing was inconclusive. So what gave us a diagnosis and a path to treatment was EUS-guided final biopsy. So we placed the stent. We brought him after 2-3 months. As you can see here, plastic stent. After 3 months, he came back, and you see the cholangiogram, and you'll see this is the pot spine he developed during that time of treatment, and the complete stricture resolution. So whenever there is a pseudotumor, my request to all of you is to consider endoscopic ultrasound mapping before you do any treatment. Now, what really changed in pancreatic fluid collections? In fact, in the morning, I shared with you hot Axios design, and this is what has changed. There are randomized controlled trials now to say that EUS-guided pancreatic fluid collection drainage is almost an established medical practice in leading centers across the world. So this is how we do with one-step delivery. This is actually a 5-minute procedure in expert hands when this is a pancreatic fluid collection. And you'll see the bolster opening up here on the real time. You can see the inner flange of the stent, and then you switch over to the other side, and that's the end of the treatment as far as this patient is concerned. So essentially, pancreatic fluid collection can be a very, very effective endoscopic treatment with 1 day of hospitalization, and patient can go home next day. So what about necrosectomy? Now, this is an interesting area. I remember I did my first EUS-guided necrosectomy in 2001, and those were the days where we never had these large metal stents, which recently came about 5-7 years ago. And that has changed a lot of scenario in endoscopic necrosectomy. So I would advise young surgeons to have a word of caution that do not jump onto any pancreatic fluid collection or WOPN with an endoscopic ultrasound to drain it. You have to map it properly. CT scan is extremely important to map whether any other extensions and paracolic gutter extensions, and these are confined area. And then you can have a minimal invasive, that is endoscopic ultrasound guided necrosectomy, or you can even combine with percutaneous approach. And we all know now that the approach to infected WOPN is a step-up manner in terms of minimal invasive surgery, and that is endoscopy or percutaneous, followed by any major aggressive intervention if you need to do that. So this is how we go inside and clear the necrosome. And at the end of complete necrosome, you can see the stent open. Sometimes we have to go multiple times, and this is what EUS allows us to do to identify the area of safe puncture. Endoscopic ultrasound guided celiac plexus neurolysis or block. Pretty much a lot of literature is there. I personally am still not convinced with this technique for various reasons, though I did probably the first in this part of the world in 1999, 2000 maybe. But I am not still convinced because we are still not doing the right thing as far as CPN is concerned. I have not been able to give desired results for long period compared to my anesthesiologist colleagues who do under CT guided CP blocks and neurolysis. Coming to pancreatic duct drainage, yes, the way we showed EUS guided biliary drainage in very difficult situation, especially disconnected ductal syndrome. When you have a pancreatic tail disconnected and it's constantly filling up the fluid cavity or PFC, then what we do is we puncture EUS guided through the stomach and leave a stent in that part of the pancreatic duct in the tail, which keeps on draining in the stomach. So these are some of the most important EUS indications in terms of diagnosis and therapy. I personally reckon this would be my slide, that recurrent acute pancreatitis and chronic pancreatitis should have a multidisciplinary management approach. So I have seen so many times surgeons, physicians, gastroenterologists say, oh, undilated duct seen on CT-MR, nothing to be done. No, you pick up small stones, small filling defects, which will not allow this patient to settle. You do a good EUS, you'll pick up. Pancreatic endotherapy, as I mentioned, is a subspecialty, like pancreatic surgery, because not every general surgeon will do pancreatic surgery. We need to understand the pathophysiology better. I feel EUS should become, in established hospitals and centers, another very important imaging tool before a definitive treatment of pancreatic diseases. I think more randomized controlled trial will need. This is a subjective opinion and observation, and I'm sure EUS will allow excellent T and N staging of both solid and cystic tumor. And as far as I feel, EUS guided pancreatic fluid collection and walled-off necrosis, to a certain extent, I think is substantiated by RCT as an established mode of treatment. With that, I conclude my talk. Thank you very much for your patient hearing.
Thank you, Vipul Roy. I think we are all, I think you can see spellbound here. That's all. I think the US mission seems to be dancing according to your command. I think the way you took us to a different planet, it looked like. I'm sure everybody is excited. We have our LP Thangaveli as a formal token of appreciation. He's going to come in, not only to appreciate your speech and also to invite all us to Coimbatore, because you are very fond of coming to Coimbatore, I know. That's why I thought LPT is the right
and I'm
person.
fond of visiting you to eat some dosa and idli at your place.
Nice, we'll serve you.
People, if the conference, the way it is going, we are planning for an on-site event only, and probably you will be more fond of coming to Coimbatore because the chief guest is one of your guru.
Yes.
No. Your guru and chief guest according to Dr. LPT.
Yes.
LP Thangavelu, over to you, LP.
Vipul,
Namaskar.
it was an amazing presentation.
Thank you.
I don't have words to congratulate you.
Thank you, sir.
You have covered everything: acute pancreatitis, stone retrieval, and cyst, pseudotumor. Everything you covered.
I could, whatever do I could do.
Surgeon doing such a wonderful work,
I have a small brief comment on that. I think surgeons know the anatomy in 3 dimensions. I have handled pancreas in my hand. I know where the organ feels which way. So I think surgeon has a 3-dimensional, image of the organ, and that helps.
Yeah, rightly said that. People, it's really wonderful of you having come morning and afternoon. I think the whole day. I think even if I wanted you to give a non-stop 15 hours of talk on US to prove the Guinness Book of Record. I think that's what your next challenge is going to be. Our wishes are, our blessings are with you. You're welcome to enjoy the idli and dosa with us. We'll move on to the next chapter. I think we have the double balloon enteroscopy, and Dr. Goendraj is going to introduce the speaker all the way from Spain, Hendrik Goendraj.
Yeah, and is Hendrik already there? He is entered?
No, he is going to join you. Please introduce.
Okay. And Hendrik is one of my very close friends for the last almost 2 decades. I have been many times to his center in Murcia, Spain. It is in the southernmost eastern part of Spain. He's one of the authority in double balloon endoscopy. And he's been recently the past president of the Gastroenterology Association of Spain. And Hendrik has written, he's an author of a book on double balloon endoscopy, on endoscopy itself. And he's one of my very close friends. And he's got, in fact, Hari was talking about the capsule endoscopy. He has got a phenomenal number of cases of capsule endoscopy got stuck in the strictures, which has been retrieved using a double balloon endoscopy. And he's an amazing fellow, and he's going to talk on the uses of double balloon endoscopy and how it is being used in the surgeon's perspective. And over to Hendrik.
Yes, I'm sure people will know how, how accurate your descriptions of Hendrik, because I had the fortunate of seeing his presentation. It's going to be excellent. Over to Hendrik, Spain.
Good afternoon. We present from Murcia in Spain our experience in double balloon enteroscopy DBE about the limits of this technique, total exploration, other organs, and the limits of the therapy. First case is a patient with a jejunal tumor with liver metastasis and capsule endoscopy retention. With a double balloon colonoscope, short type, with X-ray control, we pass a wide wire and leave the overtube in place with its inflated balloon, and then remove the enteroscope, and after we can place a stent here. You can see the capsule endoscopy in X-ray control and the stent in the stenosis, jejunal stenosis. And now, with the colonoscope through the overtube, we can see the capsule endoscopy and the stent. We need the confirmation of the permeability with contrast. Permeability of the stent and distal small bowel here. And finally, we remove the capsule endoscopy. First, biopsy of the tumor, adenocarcinoma, and remove together enteroscope and overtube with the capsule endoscopy. Next case is a RCP with a double balloon colonoscope too. We can select the bile duct and pass a Fogarty balloon or Dormia basket. Left, bile duct, Fogarty, and right. This is other case with the balloon of the enteroscope. We can see the biliary duct. And this is a case with a direct view of the mucosa and the possibility of the Beerson jejunostomy. In selected cases, next case is a big pseudopolyp with intestinal obstruction in small bowel in a patient with Crohn's disease and stenosis. This is the special aspect of the lesion. And finally, we can see very villous and the ulcers of Crohn's disease and the big pseudopolyp with obstruction, substenosis, and finally we can pass the big lesion through the ileocecal orifice. In this case, small bowel pass bowing valve and occupies the lumen of the colon without a clear image of the head of the invagination. Then, with the inflated balloon of the enteroscope, we are using a 3.2 millimeter large channel enteroscope with its overtube. We move the intestine to explore the cause of the invagination. And the existence of a large sessile polypoid lesion is clearly identified as the head of the invagination, and we wash it to analyze its surface. After washing it is not an adenomatous lesion without signs of ischemia. Then we push the lesion using the balloon of the end of the enteroscope from a favorable angle, introducing the polyp through the ileocecal orifice. We can see that the polyp is quickly back to the proximal small bowel in its original place, about 60 centimeters from bowing valve. This is the length of the invagination here. To explore the base of the polyp, we push the enteroscope and we can see, after push, the obstruction with stools. Then we inflate the balloon and pull the enteroscope to make the base more easily visible, and we inject adrenaline in the base in several points because it's very wide. First, tattoo the base, and after we use a big snare and perform a piecemeal resection with three fragments. And finally, we put 4 clips. Amartoma, and this is the clips. After this, control with capsule endoscopy was normal. This is the scheme summary of the technique. Post the enteroscope in the secant with retroversion to see the lesion. And when the polyp is through the bowing valve, it quickly returns to its place because it is not taped by the bowing orifice. Tattoo. And the next case is a biliary stent infected in the jejunum. This is the right wear with X-ray control. 2 stents after RCP 5 years ago in the jejunum with pain and now we trapped the stents with polypectomy snare, first one and after the 2 stents together, and pull with X-ray control. First, 1 stent here, and after remove 2 stents. In conclusion, we can explore the entire small bowel with capsule and enteroscopy with endoscopic treatment similar to the conventional endoscopy. We need improvement of the enteroscopes, and it's possible total exploration with all therapy. Thank you.
Thank you, Professor Hendrik. It was really wonderful to having come and joined us in the odd time. And I request our chairperson, Dr. Gani Bhaskar Rao, to say a few words regarding the way things are unfolding from this morning. I can see he is sitting there in his mansion in GSL and watching everything is going. He is our IAGES convener for people. I just want to introduce, he is one of the best center in this country, teaching all these simulations in the art of endoscopy, colonoscopy, ERCP. Over to you, sir. Would you like to add anything? Congratulate Hendrik and also the team. We are going right clockwise. Gani, sir, can you come in? As a closing remarks from you for the session, we need your felicitation. How you enjoyed so far? Unmute yourself. Please unmute yourself. Yeah, I can hear you.
It's a wonderful session. All the aspects from the upper ear to lower part of the colon, everything is covered in a different parts, including the pancreas, beautiful way. But I really want to comment that every surgeon should look at the 3 degrees of the organ. Definitely, what they most of when you're doing anatomy section, we read but only for the sake of the examination. When you're doing a practice, when you're doing a post-graduation, when you're doing a dissection, that is more successful than anything else. Like that, I think we have anybody come to our simulation lab, you can see the enterprise table. You can beautifully see all the anatomy. In rare cases, before going surgery, they can go to the anatomy, they can review the anatomy, they can operate with very beautiful outcome going to come and very less complications.
Thank you, sir. Gani sir, we are moving to the next session. Let us go on to the next session. Thank you very much for your congratulations and felicitation to all the chairpersons on behalf of IAGES and the team INDO-UK Surgicon. We thank all the chairpersons. Please log into the delegate login and enjoy the rest. And at 6 o'clock, we have a plenary sessions with 4 orations. So it is going to be endless educational material for you from our IAGES.